But thank you for joining. Welcome to today's session and for giving up your lunch break. I'm delighted to be introducing this session as part of the series of events that we're doing to support long-term condition management and understanding more about how people are managing their long-term conditions in their organisations. This is a joint event between Redmore Health, Severa and Experience-Led Care Programme. It is going to be recorded and the slides and the recording will be posted on the web pages afterwards so that you can access those. But it would be helpful to know. Yeah.
I'm really sorry to interrupt with you. There's a couple of questions, a couple of comments in the chat to say that they can't hear very clearly and there's some echoing. I'm not sure why that would be.
Is everybody else able to hear me okay? Yeah, it might just be that you need to head off and come back in and see if that works better. It might be something to do with the connection. All right. So it would be helpful to know what roles you work in. So if you could just pop your name, your job role, your organisation, where you are in the country in the chat, it'd be good to kind of see what spread we've got today. And as I said, your mics and cameras are available, but we've just popped you onto mute so we don't pick up any of that background noise. So yeah, thank you very much. As said, if you have just joined, we are recording and we'll be sharing the slides on the landing page so you can access those afterwards. Thank you. Everyone's just popping in their roles. That's great. Great to see that we've got a bit of a spread already in the south, up in Manchester. That's brilliant. Just keep those coming in. It's good to see who we've got with us today. So just in terms of the agenda today, obviously welcome and introductions, a bit of housekeeping, and then we are going to be passing on to Will at Severa, who's going to be talking about transforming long-term conditions management through their proactive virtual clinic. And then we've got Georgina and Dr. Rupa Joshi, that are going to be speaking a little bit around group clinics and how you can manage your long-term conditions through group clinics. And then we will have time for a Q&A at the end of the session. So just passing over to Sarah first.
Hi everyone. So before we pass on to our speakers today, we'd just like to hear from you. As Anna said, we can have a little bit of interaction, or if you want to put things in the chat. There's a few things really that we want you to interact on. So we would like to know how you're currently managing your long-term condition patients and the reviews for them. Does anybody want to come in and let us know?
This is where you have to get used to the silence.
Yeah.
If you don't want to come off mute, feel free to kind of pop it in the chat, but we'll just take you through the questions and you can answer them in the chat as we go.
So really what we're wanting to know is, how are you currently managing your long-term condition patients? How do you identify your cohorts? We know that there's a lot of different products to help preventative healthcare and population health management. So what kind of steps are you taking towards that? Are there any products that you're using? Do you use any ARS roles? Someone's come in my surgeries, the nurses mainly do this. I've been doing heart failure so far, but these have been identified by QOF. So really using the generic way that everyone does. You're not using any additional products or anything like that, or any ARS roles. Are there certain ARS roles that support different long-term conditions in practice? Because there's workforce and joint recruitment opportunities through PCNs. For example, not just replacing a nurse in one practice when they retire, but thinking about the service across the PCN and what roles there are out there. Also, how do you currently promote your ARS roles and educate patients to help them understand what they are and what they can offer? There's national resources available, such as animations that describe the roles that can be used on your websites, your social medias, your screens in practice. It's about instilling the trust in those roles so patients understand why they might be seen by them rather than a GP or a nurse. Ahead of patients being invited for the reviews, do you capture any information from patients beforehand, such as florries and things that can help save on clinical time, and it's also asking patients to be involved in their own healthcare. Do you ask for things like current weight, smoking status, BP readings if possible? This can then be inputted in clinical system without patients being present, and then in turn saves on clinical time and resources. And it also encourages patients, as I said, to be involved in their own care. So we've got a few things that have come up in the chat. Let's have a look. So our team support 35 practices. Some use System 1 recalls, some use Arden searches, mainly completed by admin staff. Someone else, combination of practices and ours roles, training LTC hub, practice booked on recall process, recalling the patients into the practice reports on System 1, but also use Ardens again to assist with building the searches to find the correct patients. Ardens have their own searches and we amend them to meet exactly who we want to recall in the practice. Okay, so we've got a little bit of interaction there. Does anybody else want to come in and elaborate on that at all before we do pass over to Will initially? No, you're all quiet today because it's lunchtime. If you're happy, then Will can pass straight over to Will. People can continue to add things into chat if they prefer. Currently completing a multidisciplinary group approach to support weight management with multiple LTCs. Right, okay, thank you for that. I'll pass over to you, Will.
Great, okay. Hopefully everyone can see that screen okay. Fantastic. So really helpful actually start to the questions to ask those, because I think I'll tie in a lot of the different tools that you've mentioned into this conversation. But by way of introduction, my name was Will. I'm a trained medical doctor from London, and then I went full-time into developing this service because we are quite literally obsessed with doing proactive care, and it's really great to see so many faces here today. And yeah, so just to dive in, this is the kind of the framework for the segment we're talking about today. We're going to touch a little bit about the current challenges we see and to touch on the tools you mentioned, why we developed the Subera model, how it's different. Then also focus on case studies, bringing together some real life examples of how we've influenced patient outcomes, what are the productivity gains, and how we can all save on a bit of costs, as we know it's quite at the forefront of everyone's mind at the moment. And then finally, just leave you with 3 of the lessons that we've learned from working with about 400 practices so far on long-term conditions. So I always like to start with the fact that I think we're all in a similar boat, all in the NHS, where it's slightly unrealistic expectations that we all have that is set before us. There is the balance of wanting to improve the patient experience. We don't want to burn out our staff. And then we also can't be spending too much money on everything we're doing, because obviously that's also not sustainable. And quite often we see that as one of these things get kind of prioritized, the other thing goes. And I'm sure you'd all agree that technology has already really improved the way we do lots of things, particularly since the pandemic. But in proactive care, there are currently lots of different ways of doing things, but we really wanted to tie it all together. So we're big believers in trying to innovate in this space. Not too much of a doom and gloom slide, hopefully something that most people are very aware of, but there is obviously a growing burden of long-term conditions. And the reason why it makes it more fascinating and complex for us all as people who are delivering it on the ground is that there are increasingly multi-morbidities. And with that comes a host of challenges with coordination and recall and competency mapping, which we'll talk about in a moment. But staggeringly, about 50% of all of the appointments that we do day to day in general practice are for long-term conditions. And this is only set to increase, as you can see here, in the next decade or two. So we've got a lot more fun to come. And so I think today, and I'm pleased that people in the chat have already mentioned this, but there are an overwhelming number of kind of tools and processes. You typically have a practice manager, an operations manager, or a GP partner who is kind of overseeing all the operations. There are often lots and lots of spreadsheets, a combination of both offline, using Ardens, trying to amalgamate it all together, and we tend to see a lot of different color coding going on as well. You then have the recall. You've got the manual phone calls, you've got the text messages we have to send. We also want to make sure that we don't send too many. And then you've also got to make sure that your clinical team are well staffed enough, have got availability, and are competent enough to manage all the various bits of long-term conditions. And we are just overwhelmed with the tool. So we wanted to create a simple, managed end-to-end pathway. And so these are the 4 stages that we've created. The first one being the planning, which is called the planner. No more spreadsheets is the mantra to it. We want to make sure that we can see everything in one clear, visible place. We've got engagement. How do you create multi-questionnaires so that patients can fill out all the different conditions rather than one at a time? Thirdly, which I imagine is close to everyone, is how do you automate and do this at scale? How do you see more patients with fewer appointments and with the same amount of clinical resource? And finally, to compare it and also have all of the clinical team do it as well. So we provide the clinical team and ensure that no tasks are handed back to the practice. And so Suvera is really a full proactive service for long-term conditions. In the last 3 years since we've been running, we've partnered with over 400 practices. As I mentioned, we've managed about 100,000 patients to date. We've done this in both sort of city areas, but also more rural practices. We've done it with list sizes of about 3,000 all the way up to PCNs of 160,000. And we've kind of seen a lot of the different ways of doing things. But we also wanted to recognize that it's all about making sure you cover as much as possible. So we started off with cardiovascular disease, but now we've branched out into, as you can see here, most of the kind of the bulk of the long-term conditions and the different targets that we're expected to meet. And the reason we do this is because patients are seen as a whole. And the way to get to the levels of efficiency that we want is by providing genuine multi-condition experiences for patients, which is better for patients, but also better for our staff as well. So I'll dive into a little bit about how it works. So this is the planner. And like I said, I've boldly said that it's no more spreadsheets, and I want to elaborate on what I mean by that. This is the single source of truth for all the patients in the list that need a proactive intervention. It's completely integrated with EMIS and System 1, so all the data is here in real time. And you can see here at the top, you've got your patients and you've also got the practice's patients as well. And the reason we've done that is that you as a practice can start to segment patients by things like month of birth, via risk stratification, which is very common. But you can also then start to actually allocate care to other members of your PCN team if you've got multiple staff managing the same patients. The key here is that this is a complete flexible tool for you to manage your workflow without stepping on each other's toes and ensuring that there's no duplication in care. The next stage is obviously engagement of patients. So this is our multi-channel process. This thing you're seeing here is the patient web app. We receive about 81% engagement with patients, which is one of the highest in the industry. And it may be simple, but this is a really, really important aspect, is that there's no app to download here. It's fully a web application. Patients can log in with their credentials, which is their first name, surname, and their date of birth. And you can see that they've got all of the various conditions that is pre-coded from the electronic health record. So if they're asthmatic, they've got blood pressure, all of it's here in one single place. But quite commonly, we see that actually in some of the more deprived areas, which I'll talk about a bit later on, digital isn't always the best way to reach patients. And that's absolutely fine. We recognize that it's not a one-size-fits-all. So we often do more phone calls, so telephone calls to their mobile phone, to their landline, and we also send out letters as well. And just a final piece on the design of this is we've ensured that we've tried to be as accessible as possible. So all the colours here have been vetted against the colour blindness tests. The reading age is an average age of 9, just to make sure that we are ensuring we can capture as many people as possible, and also make sure the font sizes are of reasonable size for people with visual difficulties as well. But all of this ties in because it's a automated pathway. And as some of you have already kind of mentioned, it's all about how do you ensure that the right patient sees the right clinician. And so what this is, as you can see in front of you, is that we actually automate a lot of the work. So how this translates is that if a patient, for example, here is submitting an asthma questionnaire and they're really well controlled, then they can just have a response from one of the clinical team to say everything is good and for them to do it in 6 months' time. They may not need a full physical appointment. Whereas if you do have patients who are submitting really urgent asthma readings, or they've got very high blood pressure readings, we can triage them and see them the same day. And this means that we can then start to see the patients who need to be seen because it's tied end to end in a platform. And I'll talk more about how we've done this in one of our case studies. And then finally, again, a very punchy statement, but our proactive clinic, which is CQC regulated, ensures that there are no tasks back to the practice. And the reason we can say this is because we staff the team with R's roles, such as clinical pharmacists, pharmacy technicians, care coordinators, but they're all supervised by our in-house medical team. So we've got our own GPs who supervise all of the work. Important to just recognize that everything is SNOMED coded back into EMIS and System 1, as you can see here. We configure all of the templates to meet both your local target and also national target so that you can do it all in one go. And our clinicians are equipped to do acute prescriptions, repeat prescriptions, and therefore it's as if it is delivered in-house by the care team. And so really that's the 4-stage process. And I wanted to, before I dive into the case studies, to just talk about what we view as our kind of role and position in general practice, which is these are ultimately your patients. We want to support you and we want to extend the care that you have. And so every single practice that we've onboarded, we've sat down with the team, understood the workflows and worked around that. But also you can see here on the bottom left, we do visit our practices as well. We don't want to feel like an outsider. We really are part of the team. And so really it's about embedding into your workflows and really trying to do what's best for the patients. So I'll just round off in the final few minutes with some case studies. So we had 2 large-scale projects that were commissioned by ICBs, one of which has recently won an award, the Health Tech Awards, for the Best Virtual Care Project of the Year. But I wanted to speak about them because they're about cardiovascular disease management, they're about proactive care, but it's also about how do you do that in areas that are struggling to engage with your traditional means of access. So I'll just talk about the Lewisham one. It was over a 6-month period where we invited 5,000 patients. And what was particularly interesting is about 70% of the cohorts that were invited were in the core 20+5. So these are patients who were traditionally seen as harder to reach. These are all patients with known hypertension who were uncontrolled. And so it was our task to kind of bring them into care and try to get them to completion. You can see here on the right hand side that we did send actually more invitations. And the reason we did that is because there were some patients that after multiple text messages, multiple phone calls, still didn't engage with the service, which unfortunately we do commonly see. So we adopted another route, which was also to send letters to the patients, and that also boosted engagement. And we're proud to say that we achieved 81% engagement in this cohort. This is just an overview of some of the key stats that we saw. So on the top left-hand side, you can see that just shy of 2,000 patients achieved normal blood pressure control, which is fantastic. And we also implemented a model where there was a mix of consultations and a mix of text messages sent. You can also see on the top right-hand side just how engaged the patients were with the sort of web application. So just shy of 16,000 blood pressures were submitted and 1,000 lifestyle questionnaires. And this is all about giving the onus and the power to the patients to really be part of their own care. The thing that I'm probably most proud of as a clinician from training is the 85% you see on the right-hand side. So as I talked about before, the reason we designed this kind of end-to-end pathway is that you could really truly start to deliver preventative care. And so people who submitted stage 3 blood pressures, so this is for the non-clinical people on the call, is a blood pressure that is really quite urgent and needs to be seen quite soon. With the traditional tools that we have available to us, it's not always easy to see that patient sooner. We may not have the availability in appointments. It may just be sat in an inbox somewhere. Whereas our kind of platform will pick up this patient, immediately respond to them and book them in same day. And so 85% of people were seen within 24 hours. And so just think of the number of people, friends and families who that could have been that were seen sooner as a result. And I just wanted to break down some of the cost savings. So a lot of the people on the call here are from the primary care setting. And so we were able to model it to save £1.70 for every pound invested. And this was from a combination of reductions in appointments, reductions in clinical time, and all the admin and outreach that you saw before. But fascinatingly, and I'm sure many of you will recognize this, but as the government are really pushing towards the 3 initiatives, which is technology, primary care, and prevention, this is really speaks to why this is so useful, because we were able to save about £8 for every pound invested in secondary care from just prevented hospital admissions. So that was about 40 strokes and 25 heart attacks from this 5,000 patient cohort. And so as a collective, in terms of pounds invested into the programme, which was 100k for South East London, there's about 970,000 pounds returned to the system. And as I was reflecting on preparing for this talk, I was thinking in my own life, if I knew I could save £9.70 for every £1 for something in my own personal financial life, would I do that? And the answer is absolutely yes. So the question is how do we get the NHS to invest more into this? So I did promise that I'll end with three kind of lessons that we've learned along the way. So here's the first of the three. The first one is that it's all about the competency mapping of these staff. So whenever we onboard clinical pharmacists or pharmacy technicians into the team, we survey what their skill set is, whether or not they can prescribe, and then we start to upskill them. And then on the right-hand side, you can see in the planner, we actually pre-populate every single pharmacist and their availability with the competencies. And then what this does is that all of the automations in the back end can be programmed so that all the appointments are then directed to the patient effectively. And this is a great way to make sure that you are truly not duplicating care where someone is seeing two of the three conditions and having to refer it on. The second thing is multi-conditions is super important, but doing so can be quite hard with traditional EHR appointment booking systems. So all of our booking systems are dynamic. What this means is if a patient has got multiple conditions, they get given a longer appointment. If the blood pressures or their clinical data is complex, they also get given a longer appointment. And certainly if we know that they've got an additional language requirement, they will also be automatically given a longer appointment. And the whole aim here is not about the length of time necessarily, it's about how many times they have to see the clinician, how we reduce that. And then finally, this is probably our biggest secret tip, is how we managed to kind of increase that engagement. I'm sure as many of you on the call will have tried, when you send out kind of self-booking links, we also experimented with this. We got about 30 to 40% booking from patients, but obviously that still leaves the vast majority who don't book in. And so one of the things we altered the platform to do is that we actually give them pre-booked consultations. So similarly to secondary care, we tell them a time and a date and a particular clinician, and then the patient can reschedule it themselves. And it's all about patient empowerment, and we see that this almost doubles the number of people who engage with us. So thank you. I've just hit my 15 minutes. Thank you for listening. I've also got here just a nod to our website, which has a ROI calculator. You just type in your ODS code and you can start to see the possible paths of collaboration. But I thank you all for listening, and I'm excited to hear the rest of the presentations. Thank you.
Thank you, Will. We have got a couple of questions in the chat, so it's probably worth if we get those answered first, and then we'll move on to the other presentations. So we've had a question around, is Severa available in EMIS?
Yep. So I think the question is it integrated with EMIS? Yes, we are. We're fully integrated with EMIS and System 1.
That's great, thank you. And then another was that you appear to be London-based. Looking at your website, are you able to engage with populations outside of London?
Yep, so of the 400 practices, you're right, about 55% of them have been in London, but the remaining have been all the way across the country from Cornwall to Manchester. So it's a remote model that could work in any geography.
That's great, thank you. And then another was around how is medication use fed into your model, e.g. asthma controlled due to excessive subtominal use? Do patients get a care plan, acute asthma care plan?
Yeah, really good question. So all of the care that you expect to see from our clinicians is done to kind of nice standards as well. So for particularly asthma, if a patient is being reviewed, we'd make sure they have a care plan for the year. That would be sent to them via one of our platforms as well. But yeah, certainly we would book follow-up calls with the patient if they're uncontrolled. And if it is due to excessive salbutamol use, we have video consultations to talk about inhaler techniques and to really wean that down to the appropriate use of salbutamol.
Thank you. And then the final one from Lauren is, great presentation, Will. And then out of interest, do you have any psychiatrists as well as GPs on your workforce?
Yeah, so we do have GPs on our workforce as we now moved into the extended hours as well. So we can provide kind of severe mental illness care and lots of other more complicated care that GPs are more proficient in, but we don't quite yet have psychiatrists on board. That would probably be a secondary referral that we do.
Brilliant. Thank you, Will. Any last questions for Will, just pop them in the chat, and we can do the Q&A towards the end. But we'll just, in this case, if there's no more, move on to Georgina and Dr. Rupa Joshi, who are going to be talking you through group clinics and a different approach to managing your long-term conditions. So handing over to Georgina.
Hi there, everybody. Lovely to be with you today. So I'm Georgina Craig. I'm the National Director of the Experience-Led Care Programme. I'm going to be the bread, and Rupert is going to be the filling in this little section. So I'm going to do the start and the end. So I'm going to just set this up and make sure you know what we're talking about when we talk about group clinics. Then Rupa will go through and share her experiences, which are very extensive. And then I'll just make sure that you are aware of resources that you can use to help you to get going with group clinics. So next slide, please. So after today, email that the Redmore team will send out, and we'll also provide a link to some free learning resources. We do have group clinic training programs already available in a number of ICBs, and if you pop your details into the chat, if you're inspired by, in particular, what Rupa's presentation today and would like to be doing this in your own practice, then I'll get in touch with you. And if we don't have training already, then we will be able to help you to make the case for that. Next slide, please. Also, just to let you know that we have some webinars coming up that you might be interested in. So we've got one on group clinics and women's health, and we've also got one on how group clinics help to deliver the 10-year plan. And you can also access case studies and past webinar highlights on our website. So just look out for those. Those are resources to get you going. I feel like there might be, oh no, I think that slide was a bit of a rogue one. I don't know quite why it was in there at that point, but it might be at the end as well. If it is, apologies in advance, everybody. So let's just explain what group clinics are. So next slide, please. So they're an alternative way to offer a planned clinical appointment for people who've got similar clinical issues, and their carers are able to attend if they want to. They include a group discussion about common concerns, but they also include an individual review or assessment that takes place in front of the rest of the group, where the clinician discusses biometrics and treatment and often prescribes where appropriate. If it's a video group clinic, there would be 6 to 8 patients. And if it was a face-to-face group clinic, you could have potentially as many as 12 patients. Usually you're probably aim a little bit lower to start off with as you kind of learn how to master this way of working. Alongside your clinician is a facilitator who supports the group process and makes sure that everybody gets a say, that all the clinical work gets done, supports documenting as well. A group clinic is usually 90 minutes long, unless you really have got yourself really well set up, and you're maybe have got a smaller group of patients. And sometimes video group clinics end up being more like 60 minutes with a smaller group and a really focused session. And the clinician is usually there for half the time. If you want to do video group clinics, they're usually provided on an NHS approved platform. You don't need a special platform for group clinics. MS Teams, for instance, is approved to do video group clinics. Next slide. There are 3 roles, as I've alluded to. We've got our clinician who actually does the clinical work. We've got our facilitator who supports them and is live in the session with them. And then in the background, as you've all identified, a lot of the work that is around delivering things like QOF is the admin side. So you have your clinic coordinator who is making sure that you have everything pulled together that you need for your group clinic. Next slide. So where do they fit in? Well, they definitely fit into the pyramid around what is described by Christensen as simple care. So that's planned routine care where it's driven by guidelines and protocols, and often there's a self-management or rehabilitation element to that care. So very typically where people use this in primary care is in delivery of QOF reviews. So diabetes, asthma, COPD, etc. Rupa will share with you. That's where it works best. However, when you do group clinics for this simple care, which is often the very there's a lot of volume in terms of these patients, it frees up clinician time to spend with those patients who need a bit more help, the ones whose care is more complex. And it also has a positive impact on self-care because the evidence shows that patients who are seen and followed up in group clinics make more health-related behaviour changes. So that's having a positive impact on self-care as well. Next slide, please. So group clinics are specifically mentioned in modern general practice. They are referred to as shared medical appointments, which is another name that's used often in the literature, not so much in actual clinical practice. And they're mentioned in guidance on how to improve care-related processes in general practice. And as you can see, that they're specifically referred to as something that helps to create a personalized care approach to long-term condition management. So this is recognized as something that is very much mainstream now. Next slide. So there are a number of risks we have to manage. We've got our third-party disclosure, which is, what we hear in the room stays in the room. We have to make sure people consent to share medical results in the room. And also, if it's a video group clinic, there are a couple of other checks we need to do in terms of identity and location, as you do with all remote consultations. And we have very clear NHS England signed off processes to manage these risks, which you learn when you undertake your training. Next slide. So I'm going to hand over to Rupa now. I've just sort of basically hopefully given you the facts and the figures around how these sessions work, but let's hear from Rupa how it feels as a clinician to actually deliver this way.
Thank you, Georgina, and hi everyone. I'm Rupa and I'm a GP, and I've been doing group clinics in my practice since 2018, so before the pandemic and before the PCN DES, so before we had our ARS staff. And my real motivation for doing it is really that I didn't feel that I was getting enough time with my patients. So it's almost as if the patients kept coming back again and again, asking the same questions, wanting the same thing, but we weren't really able to give them what they needed. And what they really needed was a real personalised care approach and peer support learning and really understand them to understand their conditions so that they could then learn what their condition is and how best to manage it for themselves. And the way that our kind of medical model is set up, it's very much, a one-to-one. You go through your medication, you go through your blood results, you give advice, and you do get some level of interaction, but you've only got 10 minutes, and it's really difficult to really get across all the things that the patient really needs to manage their long-term conditions. And some of our patients, as you know, have complex comorbidities, and they may have blood pressure, but then they may have diabetes, they may have kidney problems, and it's just a lot to try and get their heads around and how best to manage it. So I actually went to a training session, one of Georgina's, and it was like a little light bulb moment for me that I thought there is a better way of doing this. There's a better way of looking after my patients. So I went back to base and I talked about it with the rest of the team. And at that point, people were really interested. So Georgina mentioned a facilitator. So we had our finance officer, we had someone from workflow helping with the admin, we had a secretary. So lots of our staff really wanted, they were behind the scenes mainly, but they really wanted some patient interaction, and they wanted to feel, you know, part of the NHS, and that they were making a difference to patients. So they came in and volunteered and were kind of the support team for me. But when our PCN DES started, and our PCN, I was also a PCN clinical director from 2019. And we started off with social prescribing link workers and pharmacists. And actually, you know, it was just really wonderful to have members of our personalised care team, like the social prescribers, helping our patients to understand what the resources are in the community. Because as we know, there's a lot more to coming to the doctors because you've got a problem. There's always a story behind it, isn't there? There's always you know, employment issues, relationship issues, lots and lots of lifestyle factors and social determinants of health. And particularly if you do live in a deprived area, this way of working works really well, because using lifestyle medicine can really make a massive difference. Just one small change can make such a big difference to your patients. So we started off like that. Then our health and wellbeing coaches came on board, our care coordinators came on board, and group clinics was an amazing way of delivering care, because you now had additional resource that was above and beyond what you had in your practice to help deliver this. So at that time, we did all sorts. So we did diabetes, we did mental health using our talking therapies practitioners. We used our charities. We had our secondary care consultants come in as well. So it was a really multidisciplinary team, integrated care approach. And nowadays, what we're doing is these integrated neighbourhood teams and neighbourhood working. But this was a really good example of that back then, of how you can use all the assets that you've got in your community to deliver care to your patients, personalised care to your patients. So at the moment, what we're doing is we're doing lipids and hypertension as one, and that is delivered by our pharmacy team, along with our care coordinator and our health and wellbeing coach. And we're also doing fibromyalgia, and these were really, you know, what I was talking about in terms of the really complex patients that you've got, which a 10-minute consultation just doesn't solve, and you know, medication doesn't really solve. It's all about really understanding where they are in their own journey and what their social determinants of health are, and treating them where they are, and finding out more about them and getting them to share and understand. And when you have a peer group, they all, you know, talk to each other and get advice from each other, and they really don't feel alone anymore, because having fibromyalgia is, you know, as I'm sure you all know, is quite debilitating, and you can't see it from the outside. You might look completely normal, but you might not have slept, and you can't get up, and you can't go to work, or you might not be able to work anymore. So it's really, really difficult for these patients. So having a health and wellbeing coach who is in the room, who is really understanding, who does one little change, has a lifestyle approach, and is really able to do proper motivational interviewing, coaching with them, and also goal setting. Because what we want all our patients at the end of a group clinic is to go off with one change, and you know, how they're going to do it, what support are they going to need, what they're going to do if it's raining and they can't go for a walk, you know, all these questions to really find a smart goal that patients will actually go off and do, rather than say they're going to do. Because it's been a bit of a game changer for me, you know, trying to get patients to maybe start doing a bit of physical activity or exercise. They often say, yeah, I'll try and go to the gym, or I'll try and go for a walk. But it's really, you know, how do you nail them down so that it actually happens? And that's where our health and wellbeing coaches and our personalised care team really come in. And the other game changer is having a care coordinator that's fully funded, and an additional resource, because they're then able to do what Georgina was saying, the confidentiality, consent, they're able to do the administration, the invitations, and get people booked into the clinics, explain about it, and then do the goal setting, and at the beginning get them all kind of feeling really comfortable, and being able to just make people feel at ease so that they're comfortable sharing, because the main thing is creating a really nice atmosphere where people feel comfortable and able to talk, and it's friendly and it's smiley, and you're accepting people for who they are, and if they've got special needs, if they need assistance coming in, if they've got mobility problems, then you're there to really help and nurture them, so that they come happy and they're able to take in that knowledge and information and share their experiences. The other one that we're doing is menopause at the moment, which we do in an evening. So we use our extended access money and the care coordinator. So that's funded. And then we've got a doctor, and we get 10 women together every fortnight on a Wednesday evening, and they all come in. We're always fully booked. We've got a waiting list to get on there, and we're opening it up to the PCN as well as the practice. And before, what we were seeing was access issues, because all my clinic was menopause, all the way down, and now the clinic just takes care of it, and word gets around, so patients actually use our online consultation system or phone and say, can you book me in to the menopause clinic, please? It's not even a case of, can you book me in with a doctor? Because they all know about it, and we put it on our social media, it's on our website as well. And we've had a little bit of a lag, because we have had a nurse off sick for a little while, but we're going to go back and restart our diabetes back again as well, which, as you know, it's a process. It's on QOF, and we have the results boards that we do, which is, blood pressure, HbA1c, cholesterol. So it's really all about understanding from the patient's point of view, what is it that they need help with. And it really benefits group clinics, because it's all about lifestyle. It's all about empowering the patient with their knowledge and understanding of how they want to go and forward with managing their condition. So all of these are really good. We've also done other things like asthma, COPD, we've done pretty much all the group clinics, and we've reached out into our health inequalities communities as well. And if you have got an area of deprivation or different communities, you can think about interpreters, and you can think about if anybody that you in your practice speaks different languages. That's a brilliant way of getting engagement as well. And we've done keeping healthy during Ramadan with our mosque, which was really helpful and really engaged that community. I'm here to answer any questions, but I could talk, but I realise that we've got a limited time, so I'll go back to you, Georgina.
Thanks, Rupert. And as you say, you have done literally the whole gamut, haven't you, of group clinics? So if anyone's got any ideas about group clinic models they might want to try, then do pop a little question in the chat for Rupert and she can pick up. So we're kind of getting towards the end of our time. So just to return to that slide again, if you are interested in learning a little bit more, Rupert's mentioned obviously menopause. This works incredibly well for women's health issues, because women tend to come together in groups at challenging times of their life, or when they're going through life challenges. And so there's something about the group clinic model that is very much aligned with the needs of women. And we've got a webinar looking at that issue with Sue Mann, who's the National Clinical Director for Women's Health, coming up on the 7th of March. And then we're also going to explore using an example from Kenton Medway, where they've done recently an evaluation, how group clinics align with the delivery of the 10-year plan and the 3 shifts that we need to make. And there's loads of evidence from that learning review that group clinics are really helping that system to respond and deliver the plan. So if you would like any information about training in your area, do pop a message into the chat. If I can suggest you put your name, your email, and also your ICB if you know it. If you don't know your ICB, perhaps just put your county, because usually I can work out from the county whereabouts you are. So we, as I say, we may already have some training funded in your area. So that's it for us, I think. Hopefully you guys have got some questions. I can see there's a little thing from Rhiannon in the chat we can have a look at in a moment. So back to you, Anna, I think.
Yeah, thank you, Georgina. Thank you, Rupert. That was brilliant. As Georgina said, and the same for Will as well. If you want to pop your details into the chat, if you do want further follow-ups, and then Georgina, Rupert, and Will can get in touch with you. But keep any questions coming. I think we have already had a question that's come up from Rhiannon saying that you love the concept of these. They'll be, great in circumstances, but you're struggling to see how to discuss individual patients' results in these kind of settings. For example, individual HbA1c results. How do you discuss this with patients without feeling judged?
So some of it is down to the facilitator making it open and honest discussions. The patients all have their consent to share their results. And, I was feeling about this as well. It's as clinicians, we're all really worried, aren't we, about confidentiality. It's been drummed into us. But actually, if you listen to your patients in the waiting room, they're telling everyone about everything. And they actually don't mind because they've finally found another group of diabetics who understand. And if you've got somebody that, say, has come down from 90 to 60 on their HbA1c or something, you can celebrate that. And then the other patients will say, oh, my goodness, can you tell me how you did that? What did you do? How do you do that? So it's actually a sharing experience. And you make some group rules at the beginning and you say, this is all confidential. This is a safe space. You can talk about anything you like. So it's all about making it a really nice, friendly place. But actually, I've never had a problem with, in all the years I've been doing it, it's the clinicians that are worried about it. The patients want to talk about it. They want to say, oh, what's your cholesterol? Oh, mine's this, and what do you take? Oh, I take that. They all want to talk, and you can't stop them talking. It's really difficult because they just want to share so much that but I think you've got to do it. You've just got to have the faith and do it, because my experience is that they want to share. They want to overshare more than undershare, to be honest.
I think the other thing is that as human beings, it's really hard for us to make sense of numbers that clinicians use to monitor us. So things like HbA1c, for instance. But when you see your HbA1c compared to other people's HbA1c, and also with an optimum range, as we do show in the group clinic on what we call the results board, suddenly it's like light bulbs go off for people, and they're like, I didn't actually realize, but my sugars are so different to other people's. I need to take this seriously now. And I think, I mean, when I talk to clinicians about their experiences, and I've observed a lot of group clinics and even facilitated them, that is the almost the kind of magic that happens, isn't it, Rupert, in a group clinic?
Yeah.
Because it doesn't matter how many times you can tell a patient till you're blue in the face, you've got type 2 diabetes, your blood sugar is really high, but they don't, it doesn't mean anything to them until they're able to compare themselves with other people like them. So the people who do best in group clinics, ironically, are the poorly controlled people. What well-controlled people get is the opportunity to share their knowledge and their experience and feel really good. So it's a really positive validation of the progress that they've made. But the people who are going to really improve are the ones who are the most poorly controlled.
Thank you. I think there's been another question as well. Could you outline what an average clinic would look like, e.g. doing 10 bloods or blood pressure monitors? Can people come regularly, like a support group, or is it an annually chronic disease review?
So you can do an annual review, and you could even bring the same people back, year on year. But what we do is we've got a system for the cholesterol quaff. So the patient has their blood tests done and their blood pressure done, and then they go, or they've gone to the pod in the reception, for example, and it's high or something like that. So then they get booked in, and so you've already got their cholesterol, you've already got their blood pressure. And then I've got a drop-down menu on my blood test result reporting, which says, please book into group clinic for hypertension or lipids. And so we've got a process embedded in the surgery, which everyone knows about. The reception know about it. The HCAs who are doing the blood tests know about it. The doctors know about it. The nurses know about it. The pharmacists know about it. So everybody knows that there is a system in place for these lipid management, and then they all come in, and then there's a discussion about, you know, making sure that you're eating well, or you're doing physical activity. It's about sleep. It's about emotional well-being, stress eating. You know, you talk about what the patients want to talk about, so they bring the questions, and then you theme your answers according to that. So you've done the first bit, which is more chat, based around general questions, and then you do one-to-ones with people as you go around the room, and you talk to them about, you know, medication, or you might talk to them about, you know, how people have got their cholesterols down. You talk to them about LDLs and HDLs and all sorts. So you have all the conversations led by the health and wellbeing coach, who also does a lot of nutrition advice because that's part of their training. So Georgina does do some sessions, if you're interested, of a simulation, because I think it's really useful just to see it. And so if you really want to know more, it's a good idea to have a chat, and I'm sure there's lots of people doing group clinics across the country, and I've had people sitting in or logging in as observers as well. But the system definitely works, and the results are there. So the HbA1c's come down, the blood pressures come down. You deprescribe for chronic pain. So there's an awful lot of data and outcome measures out there that really show that it works.
I think the other thing as well is to recognize that you're not doing the bloods and things in the actual group clinic itself. So you know, with all your long-term condition reviews, you collect information in advance. And so all you're doing is you're collecting that information in advance, and then you're kind of feeding it into the results board of the group clinic. So it's not really extra work. It's just a question of doing things a little bit differently. And actually, one of the things that we've found through evaluation is that the group clinic model can help to reduce what is sometimes called failure demand. So that's when patients turn up for an appointment and you haven't got their bloods done, because that's all checked in advance to make sure that the bloods are there for the results board. So it can actually help you to improve your quaff and be more productive as well. And we should have said that probably. We haven't actually talked about that, Rupa, have we? This can save significant amounts of clinician time. So, for instance, if a nurse who would normally take 20 minutes to do a group, to do a one-to-one appointment review, they are going to be able to complete maybe 10 reviews in 90 minutes. So you're talking about more than 50% clinician time saving. So this is absolutely part of, you know, making us more efficient and effective, but also delivering person-centered care, because patients feel as if they've been with you for 90 minutes. So it's like a win-win for everybody, really.
Thank you, Georgina. So I think there hasn't been any more questions, but there's been lots of people asking for more details from both of you. So that's brilliant. And thank you, everybody that's popped their details in. I think there's actually one last question just come through. How do you allocate patients to sessions? Do you do it randomly, or on feedback, or based on similar results?
However you want. Some people theme people together. Like some people like to put the younger patients together. Some people I think a mixture is better for me, because you tend to learn from each other a lot more. So I think don't overcomplicate it, and just have them as you have them.
Yeah, if you're going to scale this up and do it as a routine way of seeing patients, which is where you'll get the maximum benefits for everybody, you just have to recall patients to group clinic. You know, so instead of offering them a one-to-one appointment, you just recall them, say we now see you for your diabetes review in a group clinic, and we'd like you to book in. And if you have people who really can't participate in a group, perhaps because they've got severe and enduring mental health issues, or they've got cognitive impairment, as an issue, for instance, then you might actually think about doing a group clinic specifically for those patients. So, for instance, imagine the power of doing a diabetes intervention in a group for people with a loved one with dementia who are having to care for them, and helping them to think about how to get them to help them with their bloods and their diet, and that kind of thing. People with learning disabilities, for instance, could come to a specific group clinic with their carers for their health reviews. So there's so many ways you can use this to actually be really patient-centered.
Thank you. Don't know if there's any more questions coming through. But as I mentioned, just pop in a message with your email if you would like either Will or Georgina or Rupert to get in touch with you, and they can pick up with you after the session. So thank you to all of our lovely speakers today. That was brilliant. Great to hear about the different things that you've got going on and how you can, manage long-term conditions more effectively and differently. As you take steps to optimize your workflows, improve patient engagement, and integrate digital tools, having the right support can really make that difference. And while we know technology is a powerful enabler, process, people, and strategy are just as important when you're trying to embed sustainable change. So I just wanted to mention our digital and transformation managed service that provides tailored hands-on support. So we can do 12-week projects or longer term collaboration, but we can help assess your digital readiness, develop data-driven strategies, and implement practical solutions to help align with your clinical priorities. And for those that are working at the ICB level, we can support with population health planning and integrated neighbourhood teams, as well, as this is becoming increasingly important. So if you would like to kind of discuss anything in terms of digital and transformation, please do get in touch with us. I just also wanted to mention, if you haven't already, you can scan this QR code to become a member of the D&T network. It's free to join. There's a wealth of resources and information on there, as well as some great conversations about all things digital and transformation in primary care. It includes a community forum. There's free webinars that we'll be delivering on there, regular newsletters, resources and templates. So just feel free to scan that and sign up. But I'd just like to thank everybody for joining today. It's been a great session with some really great interaction as well. We would like your feedback. Always looking to get feedback on these kind of sessions. So just feel free to scan that QR code, and you are in with the chance of winning a £25 voucher if you do as well. We do a raffle every month for that. But yeah, thank you everybody for joining. If you do have any last questions, we will stay on for another couple of minutes just to pick those up. But if not, feel free to pop your details into the chat, and Georgina, Will and Rupert can get in touch with you. Thanks everybody. Just stop sharing.